As you can tell, somebody that has 10% body surface area or more with psoriasis is going to be somewhat impaired. But the impairment is not just cutaneous. There's a 4 to 5-fold increased frequency of heart attacks and strokes. There's a significant increase in obesity, diabetes, hyperlipidemia, and people need to be monitored by their primary care doctors. Up to 1/3 of all people develop psoriatic arthritis. There's a 70% increased use of SSRIs. There's an increase in suicidal ideation. And in fact, the coronary arteries, when measured by CAT scans, show much more calcification than a normal coronary artery from somebody that doesn't have psoriasis. If you look at the quality of life and you compare it to the family quality of life, the worse someone's psoriasis is, the worse their quality of life is, completely correlates with their family members' quality of life, especially if it's involving in the genital areas. So people's quality of life even transcends to people with psoriasis. Severe psoriasis have much higher unemployment, much lower incomes, and it affects who they marry, when they marry, the choices they make for their profession. There has been data that's come out that shows when utilizing some of the biologic agents, you do decrease the amount of cardiovascular events. So I do believe that by decreasing the pro-inflammatory lesions, pro-inflammatory molecules involved with psoriasis, you're also being aggressive about decreasing cardiovascular risk, to the point when people in my office are on the fence about taking a biologic agent, worried about risk. I tell them that the risk of taking the biologic agent is less than the risk of not taking the biologic agent. That's kind of where I leave that. Also, I try to get involved with the primary care doctor. You know, we do some blood work prior to initiating treatment, but along the way, since there's a much higher incidence of diabetes, hypertension, atrial fib, it's important that they get hooked up with their primary care doctor at least once a year so that they can have them under control. There's also a high incidence of alcoholism and smoking, so one wants to talk to them about that as much as possible to see if they can help themselves. I would say no, not that. I think the dermatologist plays the leading role in the treatment of psoriasis and some with the treatment of psoriatic arthritis, but I don't think that the dermatologist is playing the leading role in the primary care treatment and evaluation of these comorbidities.